So I'd like to welcome Dr. VanPuymbrouck and take it away.
Thanks so much. Actually, can I share my screen?
I'll make you a co-host,
Okay.
so you can.
It's really great to see so many faces that I haven't seen for so long. Mary Kay, I haven't seen you forever. Hi, Tamar, hi. I really am very, very happy to speak to you all. I did invite Carly, Dr. Friedman, to join us because most of this information is very much, her baby. A second. But she is in Seattle on the West Coast, and it's 7 a.m. there. So she said, have a good time. Say hi, everybody.
Sleep is important.
So this presentation, a lot of the information that I'm going to be talking about is information that you all know very well. I mean, you've all written on it, you've lectured on it, but I'm just going to kind of wrap it together and talk about how Carly and I have measured ableism in different communities, and the implications for how that measurement, how those outcomes might be played out when it comes to healthcare. So I just wanted to start off by letting folks know that I am a white-skinned individual that identifies as being a female. I have shoulder-length blondish, grayish hair, and I am wearing a Rush sweatshirt, and I'm in my home office, sitting in front of a sage green wall with a bookcase in the background. And I'm just going to really start off with one of my favorite definitions of ableism. I think it's important that we all come from the same spot when we're talking about what ableism is. And to start off, this is I'm going to provide an image description of T.L. Lewis. This is a dark-skinned person with short black hair, wearing a green colored shirt and black blazer. T.L. is at a podium, glancing to the side and smiling. And their definition of ableism is that it's a system of assigning value to people's bodies and minds based on societally constructed ideas of normalcy, productivity, desirability, intelligence, excellence, and fitness. And this is their 2002 definition. Tail goes on to state that you do not need to be disabled to experience ableism, because ableism evaluates and assigns value to people based on their divergence, whether actual or perceived, from constructed ideas of normality, intelligence, wellness, excellence, beauty, and reproductivity. Ableism is embedded in really every oppression, and disability is one of the most fluid and complex marginalized identities that exists. Exploring ableism can help us really understand that marginalization and discrimination of all the different communities and groups. And having a method to measure ableism is key to better understanding it in order to begin to impact it. And please, I'm not going to check the chat. So if you can, Sarah, if anybody has anything in the chat, please just interrupt me. Or even better, I'd really like this to be a conversation. So if you have a question about it when it comes up, please just shout it out or stop me. So
I will do that.
Thank you. So ableism is really one type of prejudice, right, that exists in society. Often prejudice has been thought of in really one of two ways. You're either prejudiced or you're not. If we think of prejudice such as ableism as a Venn diagram, we typically think of the circles really not overlapping whatsoever. For example, society tends to believe either you're very ableist or you're not. This is actually not how it works. Prejudice is not dichotomous like this. In modern society, almost everyone identifies as not ableist, yet especially in healthcare. Yet ableism is prevalent and interwoven through every level of society, from institutional to interpersonal. And this slide features two circles like in a Venn diagram, except in this case, they are not overlapping. So we want to rethink prejudice and ableism as on a spectrum rather than a dichotomy means we can look at the nuances that exist. It also allows us to examine different combinations of conscious and unconscious thought. And this slide features an arrow headed to the right. It goes from blue to red to show to going from no ableism to extreme ableism. There's also a marker which shows that most people in the middle are in the middle, somewhere between no ableism and extreme ableism. So knowledge on implicit bias, and that's what we're going to be talking a lot about, stems primarily from implicit cognition theory. And I find implicit cognition theory to be really fascinating. You can go down a deep dive when it comes to it, especially if you really want to understand prejudice and how it functions. And biases are only one of many mental processes that function implicitly. Other implicit cognition functions include implicit memory, implicit self-esteem, and implicit self-concepts. So, for example, we can imagine or we can examine implicit memory and how it informs our beliefs and our behaviors. And I'm just going to use my own personal example. If we, even though we may not recall an incident, our behavior can be influenced by our experiences. So if you have a fear like I do of really large spiders, it may be that as a young individual, you had some negative experience involving spiders that really lays the foundation of this fear and informs your behavior, that you get anxious and withdraw, maybe scream a little bit when you see a spider. The science and research of implicit cognition suggests we do not always have conscious control over processes of social perceptions, impression formation, and judgment that impacts our beliefs and our actions. Implicit cognition theory also emphasizes that implicit attitudes can be positive or negative. They can be favorable or unfavorable. And importantly, there's really strong evidence that explicit biases toward many marginalized communities have reduced over the last decade. But this is likely due to decreased public and social tolerance of discrimination, prejudice, and our increased understandings of politically correct responses on explicit surveys. So additionally, we also know and must really acknowledge that many people may actually really believe that they're not biased, and in their heart they believe they don't discriminate, but still hold unconscious or negative implicit attitudes. So stereotypes, negative attitudes, and prejudice and biases develop over time and operate really at different levels. Conscious or that explicit attitudes, and unconscious or implicit. Explicit bias represents that conscious attitude that results in deliberate, calculated behaviors. Some people relate this to kind of like the slow thinking, when you have the opportunity to really reflect on what you should do or how you should behave. They're traditionally measured via self-report, such as in questionnaires, and people may feel pressured actually by social norms to conceal their biases, or they may just kind of wonder, wow, I'm somewhere in between. And they may be really unaware that they hold biased attitudes. So there are really concerns with these explicit measures and that they do not capture a wide enough of range of attitudes of people. This may be especially true when it comes to topics where it's socially undesirable to have negative attitudes, such as against people with disabilities. I want you to really hold on to that when it comes to thinking about our own experiences as a healthcare provider when it comes to interactions with people with disabilities. Implicit attitudes relate to that automatic cognitive processes, that fast thinking. Since our brains have finite power to process information, we tend to group things to help us process information quicker. In the case of people in groups and out groups. These processes are triggered by external cues and reflect associations between attitudes and concepts. And when I say implicit is unconscious, it's because it's unconscious to the person that's holding these attitudes. It's not necessarily unconscious to the targets of their prejudice. People's explicit and implicit attitudes do not always align because explicit and implicit attitudes operate differently. And because they are because they are measured differently and can be independent of one another, any individual's combination of explicit and implicit biases can be organized into 4 different categories. And this is what a lot of the work, this is Carly's dissertation, this is really the foundation of a lot of the work that she's done. So this slide features a table grid showing the 4 different prejudice styles and how they fall in terms of low and high attitudes. People with high explicit and high implicit attitudes are symbolic ableists. People with high explicit and low implicit attitudes are principled conservatives. People with low explicit attitudes and high implicit attitudes are aversive ableists. And finally, as the name indicates, people with low explicit and low implicit prejudice are truly low prejudice. So I want to talk a little bit more about each of these styles and how they look and what they mean. Does anybody have any questions right now?
Yes. Can you hear me? Okay. I do have a quick question. The use of the term symbolic, aversive, principled, conservative, and truly low prejudice. Does this come from Carly, or does this exist? Has this existed before you've done this work?
So, and I'll talk a little bit about that more. There's research within other areas, mostly racism research, that talks about symbolic racism and principled conservatives when it comes to racism, aversive racist. So a lot of this language is directly translated from research that comes from racist research.
Gotcha. Okay, thank you. That's very helpful.
Good. Thank you. Thanks for asking. Okay, so to go a little bit deeper into it, people with high explicit attitudes and low implicit attitudes are principled conservatives. Principled conservatives value abstract conservative ideas, which causes them to dislike policies that stray from societal tradition. However, research indicates principles are not consistent across people, and some principled conservatives apply and abandon their principles differently depending on group membership, such as one's race. Yes. Principled conservatism is related to ableism is significantly less common than aversive and symbolic ableism. So I'm not going to really spend a lot of time on this. And this is an area that is really in need of a lot of research. Actually, all of these are in need of a lot of more research. I actually think that this is a really intriguing community because some of my own research that looks at people with disabilities experiences interacting with healthcare providers has shown that I've had some research participants that talk about seeing the same provider in different contexts. So maybe like, let's say a nurse that's a floater that goes from one facility to another facility, and that they act much differently towards that person depending on the context that they're in. And I find that to be incredibly intriguing. So symbolic ableism or symbolic ableists have high explicit prejudice as well as high implicit prejudice. They have a real emphasis on work ethics, the pull yourself up by the bootstrap mentality. Symbolic ableists frame disability as an individualized problem. Largely there's an emphasis on overcoming. It really is grounded, this is very grounded in the medical model, and rehab professionals largely focus on this narrative. And Dr. Friedman and Dr. Awesome, another person that was at the UIC Disability Studies PhD program, used this study that you see on the bottom of the slide to translate the symbolic racist scale to create the symbolic ableism scale. Okay. Aversive ableists believe that they are not prejudiced. In fact, they hold really egalitarian values as being very important to their self-image. And they're really often very well-meaning people, yet they feel discomfort around people with disabilities and often act in prejudiced ways in scenarios where their prejudice is less overtly evident. When situations are not ambiguous and norms for behavior are well-defined, they will not participate in prejudice acts. So when there's time to reflect, time to think about their responses. In fact, without realizing it, sometimes they may even overcompensate because they've overthought it, right? To appear non-prejudiced in these situations. It's called aversive because of their own personal anxiety and discomfort around people with disabilities, and how this prejudice really is inconsistent with their own self-concept and the rationalized disassociated products of these inconsistencies, such as their behaviors. I personally think I'm an aversive ableist. I work really hard to work on it, but I think this is where I lie. Finally, truly low prejudiced people, like I said, are pretty easy to explain. They have low explicit and low implicit attitudes. They likely share perspectives of disability that align much more with the social or the relational model of disability. And they tend not to ground disability at the individual level, but they look beyond the individual to see how the contexts, the environment, the attitudes are the real disabling forces. So, any question about any of those?
I do note that Liz Madigan put in the chat that she thinks a lot of nurses are aversive ableists, and I would agree with that.
It's the largest group of folks, and I'll talk about it a little bit more, but it is, and it's you know, I mean, it's important. The reason it's important to understand where you lie is because without understanding where you lie, you won't be able to start working on it, right?
And
So,
I'd have to, Sarah, and I'd have to admit, I took the disability implicit test, and I came out as I think it was mildly favorable to people who were not disabled. And
yeah.
So I would put myself also in that category, as you did. I think it's a hard nut to crack.
It is. And I actually think it's a really great conversation to say, to kind of come out and say, yes, that's where I when I take these tests, I mean, I've taken the test dozens of times, and it really never changes. And which is something I'll talk about, but it's, and I've spent a lot of time reflecting on it, right? And working really hard on it. So,
and that was considering that for people who were transgendered, I was mildly favorable to people who were transgender versus cisgender.
Yeah.
So I'm glad of that.
Yeah, that's great, Sarah. That is good. So when it comes to measuring ableism and measuring a person's attitude, it can be really difficult and it's very complex. So it can be done in different ways. We've got direct measures, such as we've talked about, like the self-reported rating scales, and observations such as social distancing scales. And these are those explicit measures that are really easier to measure, but really they're so much easier to manipulate based on social desirability of responses. One common one is the multidimensional attitude scale towards persons with disabilities. I mean, there's a lot of scales out there. Actually, I've got a note here that there's and it's in my references. And actually, Sarah, I'll send you the my slide deck so that you can send it out to folks. But there's a study that was done by Werner et al. In 2012, entitled Stigma and Intellectual Disability, a review of related measures and future directions, that provides a really nice review of explicit measures. However, this is the scale that Carly and I've used consistently, and Carly uses a lot. It's a symbolic ableism scale. And like I said before, Dr. Friedman and Awesome worked to translate that symbolic racism scale, which is an explicit measure, and they validated the SAS, the symbolic ableism scale, through this work. And it's a Likert-based scale, from strongly disagree to strongly agree. And some of the questions are: discrimination against disabled people is no longer a problem in the United States. And the question on the symbolic racism scale was: discrimination against people of color is no longer a problem in the United States, or African American people or minority people is no longer a people. So the words were just interjected when it came to disability. So this is the implicit disability attitudes implicit association test. So if you haven't taken this test, it's really worthy of your time. To measure implicit bias, the DAIAT is really the most common, but overall there's there's not as much research on implicit measures as there is explicit measures. There's much less research using this implicit attitudes towards disability. And basically the DAIAT presents you with words such as love, wonderful, and evil, and symbols of disabled and non-disabled people, and asks participants to sort the stimuli in ways that align and conflict with stereotypes. It measures the reaction time and then compares the differences in reaction time when things align, and then also when they conflict with those stereotypes. Several studies have shown that the DAIAT's got construct validity, discriminant validity, and reliability. And research has also shown that even when participants try to fake the IAT, faking becomes very evident. So I hope, like I said, I hope if you haven't taken this, you're intrigued to do so. Just before I move on, this slide features pictures and words from the DAIAT as I described. So to look at ableism in healthcare, you all know very well that healthcare access barriers and healthcare experiences both contribute a lot to the healthcare disparities that people with disabilities experience. There's a lot of research that shows people with disabilities not only have poorer health, higher chronic diseases, shorter life expectancies than non-disabled people, but the research also reports that this is in part attributed to factors such as fewer referrals from providers to preventative care, like healthcare screenings, like a mammogram, and fewer referral to health promotion services, like smoking cessation classes. And despite being recognized as having disparate health access and health outcomes, it was just a few weeks, and not without a lot of fighting, right? That the NIH finally acknowledged this and added people with disabilities as a health disparate population. And that's after years and years of work by advocacy groups. Lots of them right here. And folks, this hopefully is a step towards increased policy research and funding to examine these more closely. But because of well-documented disparities and because disability bias is so prominent in society, we believe it's likely that healthcare providers also have biased disability attitudes, and that these inform these providers' behaviors and healthcare decisions, such as making a referral. So Dr. Friedman and I and another researcher partner, Dr. Heather Feldner, wanted to see what healthcare providers' explicit and implicit biases were. So using those two measures, what we saw explicitly, this slide shows the slide of healthcare providers' explicit attitudes. It shows almost 0% strongly preferred people with disabilities, almost 1% moderately preferred people with disabilities, 2.7% slightly preferred people with disabilities, 63.7% had no preference. So they knew how to answer explicitly, right? Almost 20% slightly preferred non-disabled people, 8.7% moderately preferred non-disabled people, and 3.4% strongly preferred non-disabled people. When we look at their implicit scores, though, this graph of implicit attitudes shows almost 1% strongly preferred people with disabilities, 2.1% moderately preferred people with disabilities, 3.7% slightly preferred people with disabilities, only 10.8% had no preference, 12.6% slightly preferred non-disabled people, almost 26 moderately preferred non-disabled people, and 44.2% strongly preferred non-disabled people. So healthcare providers aren't that much different than the larger population. These outcomes really reflect very closely a study that Carly did looking at like 350,000 people across the US. Any questions or comments here? Not surprising, right? So when exploring healthcare providers' explicit and implicit attitudes together, examining those 4 prejudice styles, we find the majority of healthcare providers, or 60.5%, were aversive ableists, 9.6% were symbolic ableists, 2.4% were principled conservatives, and finally 2.4% scored as truly low prejudice. So most healthcare providers believe that they think about people with disabilities the same as how they think about people who are non-disabled, and likely think that they provide the same quality of care. But that's the piece that really hasn't been explored yet, is to see how that is impacted with same quality of care for patients with disability as they provide to patients without disability, and believe that they make the same clinical decisions when working with people with disabilities as non-disabled people. But because of their unconscious prejudice, Carly and I and Dr. Feldner would argue that they likely do not. They likely do have differences in how they interact. So this slide just shows a pie chart with the numbers that I described. In fact, in a recent study that I'm sure most of us have read, Dr. Lisa Iazzoni and others found that more than 4/5, or 82.4% of physicians reported that people with significant disability have worse quality of life than people without disability. This same study found only 2/5 of physicians reported feeling very confident in their ability to provide the same quality of care to people with disability that they provide to people without disability, and nearly 1/2 reported not strongly welcoming patients into their practice setting. And these findings suggest that a large proportion of practicing US physicians might hold biased or stigmatized perceptions of people with disability. But you know what I find the most intriguing about this study is this was an explicit survey, right? So it kind of scares me, actually. Or maybe the physicians just are really in touch with their beliefs and their attitudes. So just a real quick, another study that Carly and I did that was an exploration of longitudinally across 4 years. It was explored the impact of OT's students' education on their disability attitudes from when they entered their graduate program. It was the summer before they started their program to after graduation. And we used the same approach of measuring implicit and explicit bias each summer across the program. And what we found was that the OT students' explicit disability attitudes significantly decreased between entering their OT program and their graduation. So what did they learn, right? Their explicit scores became more positive overall. This may have been a result of students becoming more aware of socially and politically appropriate concepts during their time in the program, or more culturally competent on issues of disability. However, their implicit disability attitudes did not change significantly throughout the same period. And this suggests that OT programs may fail to influence students' ableist attitudes. And they also show that students in this study were likely still participating in disability prejudice as the result of what we see with their implicit attitudes. And quite honestly, what this shows is they probably became more aversive ableists, right? So when it comes to the implications for healthcare, although implicit prejudice is often a lot more subtle, it can be just as harmful as overt forms of prejudice, and results in the maintenance of unjust social, political, and economic structures, as well as restricting opportunities for people with disability. In addition, what we see across these studies, and there's a lot of other studies that I didn't include, there really is a mismatch between providers' explicit and implicit disability attitudes, similar to the general population. But when it comes to healthcare providers, this may be particularly challenging because they're likely to believe that they feel positive about people with disabilities and that they're not prejudiced and provide equal care. But they still likely participate in the prejudiced thoughts and behaviors without realizing it. And so this is really the area we need to target, I think, when it comes to providers' behaviors, providers' clinical thinking, decision-making. And as I mentioned earlier, and I know all of you are very knowledgeable about, people with disabilities have significant health disparities due to the complex intersection of factors. And healthcare access barriers and inequitable healthcare experiences both contribute a lot to the healthcare disparities of the disability community. The findings of these studies using these forms of measurement suggest that it may be that implicit attitudes of healthcare providers do have a role in these modifiable outcomes. And I want to emphasize that one of the things is, in my own research, is that there really is, at least perceived by people with disabilities when interacting with the healthcare system, a term that the community themselves have described as the normalization of disability discrimination, that it's so normalized, those little micro inequities in care, like not being weighed across 20 years, by not getting up on a table because no tables exist, that really is discrimination. It's disability discrimination in healthcare, but it's so normalized within the individual provider, within the system and the social structure, that it's not being identified as such, right? It's not being identified as discrimination against people with disabilities. And we know that people with disabilities are disenfranchised, marginalized, and socially oppressed, and are the largest but often unrecognized minority group because of ableism. And I think that nail needs to be hit really hard over the head, that it's because of ableism, similar to the fact that people of color are disenfranchised, marginalized, etc., not because of the shade of their skin, but because of racism. We know these forms of discrimination, and that's what they are often intersecting. And they're also social determinants of health, and social determinants of health can be acted upon if they're identified, acknowledging their impact, and addressed, but only with long-term and system-wide commitments. And failure to take steps to recognize individual and organizational disability discrimination, subtle or overt, will perpetuate the health outcomes of disabled people. So measuring disability, or measuring ableism, and having providers recognize where they lie in the style of disability, of ableist prejudice that they have, is one place we can start. So this slide shows two forms of reaching out to Carly and I. There's a laptop and a cell phone. You see my email there. It's Laura_VanPuymbrouck@rush.edu. And Carly's is cfriedman@thecouncil.org. Please reach out if you want to talk more, if you want to participate in doing some research, or if you'd just like to talk about ways to potentially address some of these issues. Here's all the references. There's so many more.